Hello and welcome back to Unsustainable. Today's topic is very close to my heart. I was fortunate enough recently to get the chance to chat with Jessi Beyer, who's dedicated her entire career to mental health. I got a lot from our chat and I hope you do too. Please enjoy. Tell me about what you do.
Yeah. So kind of broad strokes overview, I work as a mental health professional embedded with law enforcement doing in-field crisis intervention in response to 911 calls. So that's a lot of big words. What that looks like in practice is a 911 call will come in our emergency response system, and then I go out with the first responders and do crisis de-escalation, connecting them to whatever resources they need, which range from, hey, let's get you some housing vouchers, all the way to, hey, we need to go to the emergency department right now, and really just kind of navigating that process. And then kind of as a side part of that, I also work as a negotiator and a mental health professional on our regional SWAT team. So that's a newer part of my role, but it's super exciting to get to kind of embed with law enforcement from that perspective and work on some of those really high risk type of calls, and using some of my clinical background to help law enforcement devise a negotiation strategy of, hey, what do I think is going to get everyone out of this safely? So yeah, that's kind of my day to day. My background academically is in psych. Lots of like trauma crisis type stuff is kind of my jam. And then combining that with some integrative therapies and really using a lot of mindfulness and somatic based methodologies of working through trauma. So yeah, that's me in a nutshell, I guess.
Yeah, cool. Okay, could you talk a little bit more about when you're responding to a call out, what's a typical scenario that might happen?
Yeah, that's typical is an interesting one. I'd say a lot of my work revolves around clients that are experiencing some type of suicidal ideation. So just to clarify, make sure we're on the same page, suicide is the act of taking one's life. Suicidal ideation is the consideration of it. So I'm thinking about it. I kind of want to do it. I'm building up to that suicide attempt. So a lot of times I'll get people that are calling in, either they'll call the regional crisis line, which is like emergency services, but for mental health. And then the crisis line will say, okay, we need to get someone out to talk to you in person. And then usually what happens is myself and a deputy will go out and we'll try to talk to that person and figure out kind of one of two things. One, how acute is this crisis? And the way that I look at that is everyone who's experiencing suicidal ideation absolutely needs and deserves help. But what I'm trying to figure out in this moment is, if I leave, are you going to follow through with this? Or can we connect you to resources? Can we do some safety planning, which I'll talk about in a second, and leave you safely in the field right now? And so that's one of the things that I'm trying to figure out. And then I'm also trying to figure out, how can we connect this person with an appropriate level of resource? So one of the things that I do with clients, if I am going to leave them in the field, is I do what's called a safety plan. And essentially what that looks like is a list of different resources and activities that can help get you through a suicidal crisis and connected with longer term care. Most suicidal crises, they last like 10 minutes. And so if you can get someone through that 10 minutes, they're probably going to make it to their next therapy appointment, or they're going to be able to get to inpatient the next day, or whatever that is. So in this safety plan, we're looking at a number of different things. We're looking at warning signs. So how do you know that your own mental health is getting worse? And then we look at distraction activities. So what can you do to distract yourself from this suicidal ideation until you can get to that longer term level of care? So watch a movie, read a book, go on a walk, pet a dog, whatever, like something you can do with yourself. And then we look at where you can go to be around other people. So can you go sit in a coffee shop? Can you go to the grocery store? And then we look at family and friends that you can call. So who are people in your life that are good natural support systems for you? And then the last part of our safety plan is, who are kind of the highest level professional resources. So this could be calling emergency services. It could be going to the hospital. It could be calling your therapist or calling the crisis line. Generally connecting with people that have training to help you through that moment. And so the purpose of a safety plan, let's say that, you and I make a safety plan. I'm like, okay, I'm feeling good. And the next day I recognize some of my warning signs. I'm going to do a distraction activity. So I'm going to go on a run. Okay, I feel better. I kind of work some stress out. I think I can make it to my therapy appointment later in the week. Perfect. Successful safety plan. Same scenario. I go on a run. It doesn't help. It was just a terrible run. I'm not feeling any better. So I go sit in a coffee shop, but looking at all the happy people is making me more sad. And so I call my mom, who's one of my support systems, but that doesn't really help either. And so I call emergency services and I request to go to the hospital. They come pick me up. I go to the hospital. That's still a successful safety plan because the person is still alive. And so that's really what we're trying to create for this person. And it's a collaboration, right? It's you and me sitting down and figuring out, okay, what works for me in the past? What do I like? Who are my trusted people? The purpose of that safety plan is to give them those resources and let them go as high up that ladder as they need in order to reduce their level of crisis in that moment. So kind of going back to a typical call, that's the interaction or the intervention rather that I'm going to do with folks if I'm going to leave them in the field. If I'm not going to leave them in the field, like, hey, I'm not sure that you can be safe right now, generally our next step is to take them to an emergency department for further evaluation. In my state, in the US, the way that that works is that can be done voluntarily. So they can say, yep, you know what, I think I need to go to the hospital too. We'll get an ambulance to transport you. Or it can be done in certain circumstances involuntarily. And that essentially means that the person is at such a level of crisis that they are at an imminent danger of hurting themselves or others. And so that's when we're able to say, you have to go to the hospital. And then part of my job is to make that process as easy as possible.
With what you do, what education did you have that led towards your current role?
Yeah, it's a great question. So there's two answers to this. There's the answer of what is required legally for my position, and then there's the answer of what is actually relevant that I have used for my position. So my academic background, I have my EMT license, so I am a medical professional at a very low level. I have a bachelor's degree in psychology, so a 4-year post high school degree in psychology, and I have a master's degree in psychology as well. The master's is the part that's like critical for this position. But I'm lucky. Sometimes it's been a pain administratively, but I'm lucky in that my master's program, I really got to focus on trauma and crisis intervention. So the title of my master's degree formally is Critical Psychology and Human Services. And then I focused a lot of those courses on trauma and crisis intervention. So I took an entire course on trauma counseling. I took an entire course on sexual assault in its various forms. I took an entire course on PTSD in military and first responder populations. I took an entire course on peace psychology. So like war and the military and stuff like that and the psychology of that. So I really got to drill down in this kind of trauma and crisis intervention side of things. Going back to the title of my degree, critical psychology as opposed to clinical psychology. Critical psychology is essentially an analysis of how mainstream white American psychology has screwed over a lot of minority populations. And I'm totally happy to dive down that rabbit hole. But just to answer your question, most people in my profession have a clinical psychology background. That is a lot of diagnostics, assessment, different therapy modalities. What I care about is not what diagnosis is going on your paperwork. What I care about is how do your symptoms affect your life? And so if I can see, oh, depression, they're down. Okay, how can I work with down? They're anxious, they're up. How do I work with up? How do I regulate the ups and the downs? Those are kind of the questions that I'm asking. So a basic understanding of diagnostics is helpful. A basic understanding of psychopharmacology is really helpful as well, because I work with a lot of clients who are like, I don't have a mental illness. Like, there's nothing wrong with me. My mental health is perfect. And then you look in their cabinet and you see risperidone, for example, which is an antipsychotic. So that's helpful. The biggest skills that I have learned, though, are basic communication skills, and not just things like talk to someone and show empathy and tell them that you care, but like the very specific tactable phrases that I use when I'm talking with someone. That is not taught in a counseling program. So that has been exceptionally helpful. My courses as a negotiator, my training as a negotiator has been incredibly helpful. And then also my very limited, I'm still trying to get more knowledge of threat assessment. So the biggest, I guess, resource for that, the FBI puts out like an 80-page booklet on threat assessment. And it is wildly helpful. It's just even the model of the pathway to violence that they teach is so working with clients that are like, where on this spectrum of wanting to enact violence on oneself or others are we?
And what's been the source of some of this extra education that you've been picking up along the way that's been super useful?
Yeah. So there's one, just kind of going through those main categories. There's one green textbook. It's like the Psychopharmacology Handbook for Clinicians, 5th edition or something. I don't know what, something like that. It's literally like a drug textbook. That has been super helpful because it talks about common drugs for the different types of mental disorders and also gets into some of the neurology of like why these things work. And that just even understanding dopamine, like if you can understand what dopamine does, you can pretty much understand psychosis, and how it is affected and moderated by different drugs and things like that. So that book was really helpful. The FBI guide that I mentioned is free. It's online. That's really helpful as well. The courses that I took in negotiation, the company that hosts them is called Crisis Systems Management. They're like the national standard essentially for negotiation training. I went through their 120-hour certification program. That was super helpful. I took a 6-hour suicide prevention training through the University of Washington here in Washington in the US. And that program plus the negotiation training gave me most of those like crisis intervention-y type skills. And then I would also say that a lot of my specialized courses that I took in grad school, some of the ones that I mentioned, as well as the framing of critical psychology and how that really forces you to look at the whole picture, not just the person in this moment with this diagnosis, but like the whole context of this person's life. That has been very, very helpful framing, for not only working with clients, but then also understanding what sort of resources do they need? Are they going to engage with them? How can I help them engage with them? And different things like that.
I was wondering too, is your role fairly unique to the police department where you work, or is it quite common around the country?
Yeah, it's a great question. So my formal title is co-responder, which I am co-responding with first responders is kind of the concept of the title there. Co-response programs do exist nationwide. I think maybe even internationally. I don't know anything about the international kind of field when it comes to co-response. These programs do exist nationwide. It is a new-ish field. I think the first co-response program started cropping up maybe 10-ish years ago, and then has slowly picked up speed since then. And when we're looking at like emergency response, I consider that new still. Because I mean, we've been doing therapy for hundreds of years, but putting mental health professionals in the field of law enforcement is still pretty new. In my area, so I technically work with 2 different police departments and then 3 fire departments. I am the only co-responder. Like it's just me. That's all we got for that area. There are other programs within an hour or 2 hours drive of me that exist, but for the area that I cover, I'm the only one that does this type of work.
That's quite a big area then.
It is geographically quite large, yes. So to just give a little bit of context to it, and this is relevant for the type of work that I do as well. So if we're looking at the US, Washington is the state in the upper left-hand corner. Within Washington, Seattle is like the big metro area, and I am in the county above Seattle. So my county is the second most populated county in the state. In the state of Washington, there is one main highway that runs north to south through Seattle. Pretty much if you get 10-ish minutes off of that highway in either direction, it becomes a very rural part of the state. And so I specifically work in the county above Seattle, so very populated in general, but I work the east part of that county. So I have all the rural, unincorporated areas and the small towns to work with. The reason that I highlight that is that, yes, it is a vast geographical area, but the other reason I point that out is because it means that there's not a lot of resources out there. We have one hospital, one emergency department that covers that entire area. And quite frankly, it's terrible for mental health related clients. I will always try to push them towards a hospital that's closer to the populated area that has better resources, but that's the one that we have. Additionally, in terms of other kind of human services type resources, like the community resource centers or private practice therapists, all of them close at 5. And so once we get after hours into that evening time, which is when I work, I'm quite literally it. And so it is a very unique place to work in the sense of after hours when things are closed down, like everything kind of gets shoved on my plate, which means I see a wide variety of different cases. But it also means that the culture is a little bit different because it is rural. It's a little bit more conservative politically. It's a little bit less inclusive in some ways. And so that can cause crises for some clients that don't fit the traditional mold in that area. But it also just means I have to get creative. I don't have 15 resources that are open 24/7 that I can send someone to. Like I have to figure out what's open now, probably nothing. Okay, what's open tomorrow? And how do I make sure that you're safe until then to connect with those resources?
Yeah. And I'm guessing you don't work 7 days a week.
I don't. No, I work 4 days a week.
And what happens the other 3 days?
That's not a whole lot. A lot of emails to Jessi saying, "Hey Jessi, when you get back on shift, can you please call this person?"
Oh, dear.
Is usually how that works. The deputies and officers that work the other half of the week, they're awesome. And I do want to highlight that. Like, I am not a miracle worker. I'm one human. I have a skill set that I can help. But all of the officers that I work with are phenomenal. Like, I am so blessed to have such good partners out there.
Yeah.
And so they will handle the calls themselves, just like they did before I showed up, and just like they will after I'm no longer here. And so they will do what they can. And then oftentimes they will kind of shoot me an email saying, "Hey, I met so-and-so person, they're struggling with this. Can you give them a phone call if you have any resources that you can offer them," or something like that. So that's part of the work that I do as well.
Nice. How many co-responders are there in the greater Seattle area?
Ooh, that's an awesome question. I don't. Okay, so we're going to do some mental math together here. There's me. Everett Police has a full team of 8. King County has a full team of 6. It doesn't really matter if you know where these places are. I'm just kind of counting the numbers off my head. Bellingham, between their alternative response team and their co-response team, I think maybe have another 6 or 8. There's probably, with all the different teams that are in the state of Washington, we probably have close to 100 co-responders.
And is Washington different from other states in terms of how it's structured, or the policies? Or
every state is different, which is just so helpful when you're trying to talk to teams that are across different states. One thing to note about Washington is we are very politically liberal. And so we have generally more resources and more inclusion for mental health than some of the other states in the country that are not quite as politically liberal. But I wouldn't necessarily say we're like the pioneers of co-response or anything like that. We've, there's a lot of different programs across the country that have been around for a while as well.
Interesting. What are you imagining for the future?
I would love to see more co-response programs, more integration of mental health professionals in the field. For a while, and this definitely still exists, especially in politically liberal places like Washington, this push to replace police officers with mental health professionals, I think it's a terrible idea. I need the partnership. Law enforcement has skills that I do not have. I am able to do my job because I trust my partners, and I trust that they are going to physically take care of me and take care of all of the safety things. I don't have to worry about that. I can just focus on the client. And we have a complete understanding that any of them can grab me by my ponytail and yank me out of there if something is going wrong, but I trust them. And so that partnership is absolutely necessary. So that's why I advocate for more co-response programs, more integration of mental health professionals with law enforcement. We bring skills to the table that they don't have. They have skills that we don't have. And together we're both suited to this type of work. So that's one thing that I would really like to see is more co-response programs. I also, and this is kind of going back to more of like my integrative therapy type side of things, I want to see more options presented to people for healing. A ton of the clients that I work with have long trauma histories. Maybe what they're presenting with now is homelessness, for example. Like, that's what they're struggling with. They're living on the streets. They don't have anywhere to go and they need some help. But when you start hearing their story, maybe they've overdosed before. Maybe they've been sexually assaulted. Maybe that they were physically abused by a parent when they were a kid. All of these different things that have led up to this person's current circumstance, and all that is trauma. And with the American Psychological Association, like I mentioned earlier, they really hammer home talk therapy and meds for trauma. And as we already talked about, that'll help, but it doesn't always work. And if you read some of the studies, kind of conglomerating them, it shakes out to about 50% of people benefit from those types of interventions. That's great. That's awesome. And I love that for that 50% of people. But what about the other half? And what happens when that other half is told, sucks for you, like you couldn't comply with the therapy, or this is your fault that it didn't work. There's nothing else that we have to offer. When in reality, that's not true. There's so many other things that we can do to help people work through this trauma that they've experienced. And so where I would love to see the field of trauma go, like the field of trauma treatment go, is more expansive in terms of treatment modalities, and then also looking younger and looking more holistically at the person's life. As another example, a veteran who's coming back from war and is struggling with PTSD. Yeah, they saw some stuff, right? They definitely saw some stuff, but were they already growing up in a household where there was addiction and violence? Were they already primed to have a negative response to the trauma that they experienced? Or are they coming back to really solid support systems, a really grounded home, stability financially, all those different things, really just kind of looking at this person from a holistic lens and not just, you saw a trauma, here's a medication, now go away and don't come back, which unfortunately is a lot of the treatment that veterans get when they're coming back from combat. So, yeah, those are some things that I guess I would like to see in the future. And I think at least from a co-response perspective, we're getting there. There's a wonderful conference every year, the National Co-Responder Conference. And again, you live in your little bubble where you work or where I work. And then you go to this conference and you're like, there's hundreds of us and there's so many and we're all doing really cool things. So that is growing and that is happening. I think the integrative trauma side of things is a little bit slower to catch some wind in its sails. But I do think that we're getting to a broader recognition, especially with some of the studies that are coming out related to, again, trauma sensitive yoga, as well as kind of psychedelic assisted therapy, which is a whole nother rabbit hole. But we're starting to get a little bit more recognition in kind of the mainstream psychological field of the benefits of some of these types of therapies.
And even then, the talk therapy and medications, it may benefit 50% of people, but a benefit is not a cure.
Yeah. And what's interesting about that too is if you read the studies, like there's the headline of 50% of people are healed by this therapy. But if you read the study, so when you're diagnosing PTSD, one of the standard checklists is kind of a scoring system where it's like, hey, if you experience these different symptoms, then you have PTSD. And so you meet the clinical criteria for having PTSD. And so if you read the studies, some studies say that a successful treatment is someone no longer meets the clinical threshold. So their symptoms have reduced enough that they don't technically have PTSD anymore. That you could consider a cure, maybe. That's a whole nother discussion of like whether I think you can actually cure trauma. I personally don't. But a lot of studies also just look at clinically significant reductions in symptoms. And so what that means is that if here's the clinical baseline, someone comes in up here, their symptoms reduce to here, that is a statistically significant reduction, but they still meet the criteria for PTSD. Like they're still having significant enough symptoms that diagnostically they still have PTSD. And so you kind of have to get in the weeds when you're looking at these studies of like, did they actually get rid of their diagnosis or did they just get a little bit better? Incremental change is good. Like I'm not saying that's a bad thing, but it's not just as broad as like, oh, it worked. Okay, how well did it work? What did it work to? What is this person's life like now? And again, getting back to that holistic view, great. They reduced their symptoms from, this is not how it's exactly scored, but like from a 9 out of 10 to a 7 out of 10. But what does the rest of their life look like? Can they hold down a job? Can they have a relationship? Can they sleep through the night without nightmares? Like, what does that look like? And how do we address that holistic view? So yeah, that was kind of a side rant. But yeah, there's benefits, there's cures, there's also a lot of people who are not helped. Or with certain types of trauma therapy, the attrition rate is so high. Like the number of people that drop out of that treatment is so high. And then also with some therapies like exposure therapy, that is essentially exactly what it sounds like, right? Like you are looking your trauma in the face over and over and over and over and over again until it's not as traumatic anymore. And that's kind of hard and painful and uncomfortable and triggering and all of those different things. So understandably, a lot of people drop out. For the people who don't drop out, it can be very, very effective. But what some studies and some media outlets do is they'll be like, oh, exposure therapy had a 98% success rate. And you're like, oh, cool, let's look at this. And then you read further and you're like, 80% of participants did not complete and were not included in the final data set. I am not anti-talk therapy. I am not anti-exposure therapy or anti-medications. Like I love every healing modality that we have out there. I just want us to acknowledge every healing modality that we have out there and give it enough attention in the academic literature that it can be more broadly accepted in the world of healing.
Yeah, everything that works should be accessible to everyone. It's quite simple, isn't it?
Yeah. That should be my new headline. I'm going to steal that. I like that. That's it. That is it in a nutshell. That's what I've been saying for the last hour in a nutshell. So, yeah.
Very cool.
So again, I am a fan of talk therapy. I'm a fan of medication. I'm a fan of research. I'm a fan of Western people. And I'm a fan of Indigenous and Eastern and feminine healing methods and nonverbal healing methods and understanding generational trauma and healing in community and looking at the holistic life picture of someone. And that is what I would love to see more of in our field of psychology in the future.
It definitely feels like we're moving in the right direction. Like obviously
I think
things could turn and things could go terribly wrong, but I do have some hope for the future.
Yeah, I do too, because there's more people that are talking about this. I mean, the fact that a critical psychology degree even exists, like that didn't exist 10, 20, 50 years ago. So the fact that people are talking about this and there are journal articles being published on this, like we're getting there, we're getting somewhere. And so it is a slow process of pushing a large boulder up a steep hill, but I think we're moving in the right direction with a lot of this stuff.
I really like that analogy though. All it takes is someone to slip, the boulder's gone back down.
But also, like, that's kind of true. Like, if you know, it's when something is new and fledgling, it's easy to get knocked off course. But I think that to continue that analogy, we have enough people pushing the boulder that if we can weather the storm a little bit, like we can have some things happen and still be able to advocate for clients and for trauma treatment that I think is more holistic and effective for people.
Yeah. So if people watching or listening wanted to learn more about what you do and the sort of initiatives and organizations that you support, where would you suggest that they go?
Yeah, so my website, jessibeyerinternational.com. I'm sure we can link some of this stuff in the show notes in the YouTube description. My website, jessibeyerinternational.com. I'm on LinkedIn, probably the most, is kind of my social media platform of choice. And then you also can find me on Instagram, but I'm like rarely there. So LinkedIn and my website are probably the two best places to get in contact with me. I welcome emails, messages, conversations. Like if you have questions, if you want to debate something I said, if you want a resource or you want help getting pointed in the right direction, like please reach out. I welcome any of those conversations.
Cool. Well, thank you very much, Jessi. Thanks for your time. Thanks for everything that you do. And wishing you a safe and lovely day.
Thank you. You as well. Again, thank you for the time. I had a ton of fun.
Pleasure.
Bye.
Bye.